As it turns 9:40. Good morning, everyone. I am Leanne Lau. I'm one of the palliative attendings at Medical College of Wisconsin, and I'm delighted today to be moderating for our Chalk Talk this week. Our topic today is how we can connect our electronic health record to serious illness care. Deborah Unger and Tom Chiantifilo, sorry, I did my best, are going to be talking with us, and I'm going to let them each introduce themselves because they told me the lovely list of things they're doing, and I tried to jot it down, but I think they're going to do a better job of sort of saying why they have a good connection for this topic. I was excited to sign up for this, though, when Marty presented the options for moderating, because I think, number one, I have a history of doing stuff with the EHR and Epic and all that, but I think that one of the significant frustrations in healthcare in general is this connection of how this machine that we keep typing into all the time could actually be a tool that's useful for us rather than just a burden. And so I was really excited to see what thoughts they have about connecting this to the work that we're doing. So I think with that, I'm going to let you guys kick it off. Deb and Tom, if you wanted to go ahead and roll, that would be great.
Good morning. Thank you for having us. We're excited to share thoughts about the electronic health record. My name is Tom Chiantifilo. I'm a geriatrician at the Christ Medical Center. I was involved in a cut over and adoption of an Epic ACP Foundation module. And Deb, do you want to share a couple words about yourself?
Yeah, thank you. My name is Deborah Unger. I'm a palliative care physician by training. I was working for several years in the Nashville area at the VA and at Vanderbilt, and was involved with the VA's transition project from CPRS to an Oracle Cerner project, working on the palliative care pieces of that for the Office of Electronic Health Record Modernization. And about a year ago, I joined the Providence Health System on the West Coast as the Director of Medical Informatics for the Institute for Human Caring, which is the system-wide arm looking at education, innovation, and sort of dissemination of best practices for serious illness and whole person care for Providence.
Today's objectives is to look at the current state and challenges related to the electronic health record and serious illness, to list the top 10 design principles to consider, but we're going to focus on 3 of them. How many patients have advanced care planning? So the definition of advanced care planning within the literature can vary. It could be like a post, it could be power of attorney for health, it could be a discussion, but it's approximately 30%. It's varied by populations, is it outpatient, inpatient? And how many patients need an advanced care plan or goals of care? So I was looking at the American Hospital Association. So we have about 6,000 hospitals. We have about 920,000 beds in the United States. ICUs, we have 112,000. Total admissions is about 33 million. And patients older than 65 in 2019 were about 54 million. So that is a huge challenge. There's many locations, many patients, many special circumstances. So we looked at the literature and we did a search on electronic health records, advanced care plan, and placement of notes or orders. So there's 4 articles in 10 years. So of course, there are going to be other ones within, abstract conferences and whatnot, but in a broad literature search, only 4. 2 of them are from the same author, which is Dr. Obel. There's one in pediatrics, like before age 18, and there was a Hubbard 2018, looked at several studies, and they had a couple of conclusions. One of them was that we need a real-time prognostication process to prompt when the ACP review needs to take place. We need to consider that we're making global changes, like many notes, many orders, and then we don't study the effect of each one of those pieces. So there's a gap in effect. And the order, they're commenting that there's code status. So there could be other orders that could be associated with advanced care planning or managing patients with complex illness. With Dr. Obel and her colleagues, they had 2 articles. One of them was on thoracic surgery. The other one was outpatient. And essentially they were asking these questions: whom to reach out to? Does that person know your values that they're being reached out to? And are there shared ACP documents? And the process, and I believe many of us may be gravitating to that a physician could prompt or initiate the conversation. There could be a support group like nursing social work that readdress, answer questions, and then reach the point where the physician can finalize, be it in a pulse form or other documentation of what's happening. I would say there's very limited evidence of exactly where we should put our notes, like when to do them, how to do them, and whatnot. So the current state, I would propose that is a potential disarray where the information, delegations, orders can vary as within a system, but especially across systems. And the question is what is needed. So you need to start with terminology, like every system, even within various groups within the system, we don't use the terms consistently. Let's say substitute decision maker versus surrogate. So the dream would be to the left, where it is this network of information, patient portal, that kind of feeds into a system. There's a person, it's reflected in the record reflects within the notes and the orders what's happening. And the thing to consider is, based on my experience from trying to put the module into place, that it's not just the medical piece, it's also the psychiatry piece that is very important because it has very unique advanced care plan characteristics. So there's a couple options. I'm not sure if in the chat people want to say A versus B. A would be blue, B would be yellow. I don't know if your system supports having an advanced care planning discussion, documentation, use of goals of care over several years, assessing the capacity, and if they don't have the capacity to engage the substitute decision maker or the guardian. The other option that I see quite commonly in the hospital, all of that work suddenly gets collapsed into 1 day, 2 days, 1 week, where the ACP, goals of care, capacity, substitute decision maker has to be done sometimes by a person that the family has never met, so they've never really bonded with them. So I would propose that this is a huge challenge. So I'll be curious, who's A and who's B, but I would hope that we are gravitating towards A. So the logistics needed, it is training the staff to provide this information. I don't believe that it can be only done by palliative. It cannot only be done by certain physicians. Considering how to have in-person and virtual visits, and how to retain the staff once you build those teams, to be able to have follow-up items, and thinking about operation reports where there are patients that should be identified, that they should have these discussions, and that we capture it in a certain way, and looking at the outcomes. Are we increasing hospice use services? Are we decreasing ICU length of stay? However we want to structure it. So I would say pulling in from other EHRs, outpatient patient portal interface, which we have in the sense, but it's not structured, at least within Advocate, providing educational material, having hotline to be able to answer questions around advanced care planning and appointments. So in the electronic health record, we need to have that structure to be able to defer or reach out to say, well, the patient is interested, can you follow up on that? Deb.
Thanks, Tom. And I'll just say in my experience that it mostly tended to be B, and I agree with you that shifting towards A is a vital, important goal, because having those conversations with people you know and trust, I think, makes all the difference in the world. But just shifting a little bit and kind of taking a kind of 10,000 foot view is, so at the Institute of Human Caring, we did some essentially listening tours for palliative care clinicians across our system, which encompasses about 7 states on the West Coast. And a lot of sort of venting was done about the EHRs and hurdles discussed. And so we recently kind of sat down and started thinking through some of the top design principles to keep in mind when designing or building for the EHR. And again, this is with the caveat, Tom and I, Advocate Aurora and Providence are both on the Epic vendor health systems, but I have worked with Meditech, Cerner, CPRS, many others. And so these are really meant to be design principles, but obviously we don't have time to go through all 10 of them. So I just kind of wanted to go ahead and highlight the top 3. So the top one talking about is talking about what Tom was alluding to in terms of this Holy Grail is to have all of the information that's important for serious illness care or whole person care or palliative care or geriatric care that you're doing in the moment in one place. You're not having to go to notes here or consults here, images here, labs here, assessments or patient reported outcomes, and try to get it into the most streamlined documentation process as possible. The second piece is this question about balancing customization versus standardization. And it really is a balance, because standardization makes things easier in terms of onboarding new providers, doing ongoing education, when you have setting sort of standards of practice and best practices, especially when you're dealing with inpatient and outpatient palliative care, hospice, geriatrics, and setting that across an entire system or facility or institution. But also recognizing that not one size is going to ever fit all, and that you need to be able to create some custom pieces, and the more power that you give people to create some of those custom pieces for themselves, the more familiar and desirable those tools will be. But you also don't want to create it in such a way that like everyone has their own custom piece, and every time there's an update, you have to tweak every single person's, note template. So it's a balance between those two things. And the other main thing that we're talking about is use it or lose it, which is actually what this is. It's the ongoing education. It's familiarizing yourself with the EHR. The single most important factor in increasing provider satisfaction with their EHR and for reducing burnout related to the EHR is education and familiarity with the EHR. So moving on to just kind of highlighting, Tom, on the next slide, this Holy Grail that we're talking about. We've done the conversations. We know where to go in the EHR to put this into the record. Once it's in there, I know where to go back and find it. And also I can create action based on those conversations in terms of orders or follow-up, or messaging other parts of the care team. So this is just an example. This is based on, as I was mentioning, the listening tours we did at Providence. And this is based on talking to multiple palliative care and serious illness and geriatric programs across the Providence health system. And as you can see, there are a lot of people who have adopted the standard workflows, what they call the foundation system tools that come from Epic, but a lot less have implemented those advanced features. So developing custom clinical decision support tools or dynamic documentation. Very few have developed specialty palliative care reporting practices, and only 18% do any sort of formalized onboarding that specifically teaches and educates about advanced care planning in the EHR. So getting at this Holy Grail, this put everything where you want it, there are several approaches to this. And so we're going to highlight both Providence and Advocate Aurora's approaches. And so this approach is what we use at Providence, and this is sort of an excerpted example because we're officially not allowed to use Epic screenshots. But this is essentially what it looks like. So we have what's called an advanced care planning report summary tab. It's right under a chart review. It's one of the summary pieces. And there is a version of this that is built into the foundation system of Epic, so it comes standard. But this is kind of the custom one we've developed. We have these 4 color-coded tiles at the top. One is for code status, one is for the presence or absence of a electronic post or physical post. The third is for the presence or absence of an advanced directive. And the fourth is for goals of care documentation. And for us, that can be either a goals of care note type or use of the serious illness conversation guide, which you can actually get to through this summary page through a navigator, as well as we have an integrated goals of care note type, which is a whole separate conversation. And that underneath each of these tiles, we then have additional information about each of these pieces. So under the sort of the orange color coded one, we have all the prior code statuses, when and who they were ordered by. We have prior pulse if they were voided. We have all the advanced directive or living will or legal documents. And then we have all of the goals of care notes with links to those individual notes that you can get to straight from this tab. So you can go review the last 5 goals of care notes straight from this patient's summary page. So Tom, maybe you can talk a little bit about Advocate Aurora's approach.
Now with Advocate, we had a legacy component. So when our Wisconsin side, and we've expanded since we merged with them, Epic did not have ACP material per se. So there was a lot of material for like a decade. So the first challenge was to cut over from an old system to a new system. In essence, the ACP Epic Foundation Navigator was adopted, but there was an ACP GOC note that is used, and it's designed to be one solid piece, but depending on if you're inpatient, outpatient, in essence, it will have like certain phrasing that would capture what would be necessary. There is an SDM selection. There is inpatient redirection to support staff, but not for the outpatient entities. And then there's print groups, which essentially let the user know what used to exist in legacy and what is existing currently. Be it the ACP Navigator, which is essentially an entry point to put information and look at it, including with the notes. Ultimately, that updates a visual board. We call it the storyboard, where it lists the guardian, the substitute decision maker, if they're active, and the code status. So it's a different approach. Deb, any design challenges that you want to mention?
Yeah, I think I probably don't have to tell anyone on this call that dealing with the EHR can be frustrating at times. Dealing with your IT department and analytics can be a little frustrating at times. But some of the things that I think pop up over and over are making sure that we're engaging everyone, that we're communicating and telling people, what, especially when we build something or when we change something, where to go to find that, or what the change is, and how we disseminate that information. And I don't know about you, Tom, but at least at Providence, it's always, you send out emails and then maybe a little bit later, someone is like, but where do I find this? And you're like, oh, it was in that email. But it's it's always you want to be as graceful and as patient as possible. And then also when you're doing all of this, you have to make sure you're balancing sort of narrative text and discrete data capture. I think that's also a big one to think about when you're designing things. And also, you know, how to know that you're measuring what you want to measure and reporting, which is a kind of a whole other big topic. But I think that's important to think about when you're designing these pieces, because if you don't put it in at the beginning, it's going to be hard to put it in the back end.
One thought, Deb, is phrasing the need based on safety. Like that you say, I have this patient, 2 patients, 10 patients, you know, the system is great, but in my case, I would like for you, and be very specific, just filling in the blank. And I call it the cupcake rule, which is, you know, the system ultimately needs to bake a cupcake. If it doesn't bake a cupcake, the system is not working.
Yeah, I totally agree. And I think that, again, I'm preaching to the choir on this call, but telling a story is always really useful. I think, you know, obviously patient safety is one of those big things to tie it into, and to also use that, you know, like use that as your sprinkles on the cupcake, maybe, because it's been used so many times that it's almost like a buzzword now. So if everything is, you're doing everything for patient safety, you're doing nothing for patient safety. But to really like tell that story and tell why safety in that example is important. I totally agree. But we also want to start wrapping this up and move on to questions. But kind of one of the things that I hope to get across is that the more that we sort of abdicate our role in EHR design and function, the less it's going to be designed the way we want it to be. And I think that siloing medicine and informatics or IT is the practice we've been on in a long time in medicine. And I think more overlap will only do us good to get our back into how these pieces are built and used. So some of the things to look into are seeing if there are sort of clinical decision support teams at your institution that you might be able to join. Most of the ones I know are like, a doctor or NP or chaplain or social wants to join us. That's amazing. So it's usually met with a lot of enthusiasm. If you are on the Epic platform, I really can't actually support enough their super user, power user classes. They're free on the Epic user web. They're really well done. You get CME for them too. There's also some really nice forums on the Epic user web. Going through the Epic Physician Builder pathway, which Tom and I both have, has been really eye-opening in terms of what sort of is and isn't possible in designing the EHR. And then there's also newsletters and videos and updates that they send out. And then in an absolutely shameless plug, Matt Gonzalez, who is the CEO and CMO of the Institute for Human Caring, and myself are doing a pre-conference workshop at AHPM in Montreal this coming March on specifically the use of Epic in serious illness care. So if anybody wants to do a deeper dive, we're going to be going through all the top 10 principles, and then we're actually going to be doing a live design sprint during the session where we live build and hopefully solve a problem for someone in the conference. And so please join us if you would like to.
We're open to questions, unless Martin, you have any other thoughts?
I'm going to just thank you both so much. That was really interesting. I'll start off the questions and then we'll see. I'm not seeing anything in the chat right now, but feel free to, for the audience, raise your hand or type in the chat that you have a question, and I will actually call on folks just to keep things sort of organized. My first question that really struck me when you all were talking, there were a lot of things, but I'll maintain composure here and stick to one. The idea when you were saying a way to keep track of where you are in the process, I think that's an interesting part of why it feels like it's all done at once and last minute, is because it's not clear when it's been done before. So I guess if either of you could talk a little bit to how some of these tools would help with just keeping track of what's been done. If it's not completed all the way, you know, you didn't get the ACP done, but you definitely had conversations or whatever it may be.
Or at least in our case, we're trying to use the notes and use it one type of note and then modify it so that it's, you know, an ongoing conversation about the best approach. But then that creates, you know, there's anchors within the note where it flags and it pulls it specifically into what we call a printer group, but it could be, you know, other names for other EHR vendors. The beauty of what I've seen this far is, like, they don't say patient sleeping hasn't been seen. They actually, you know, put something of meaning in there. I believe it speaks towards the collaboration with physicians and HIT that Deb was mentioning, and it becomes meaningful. The challenge for us is that a lot of the information we share about how to go about this process and how to create that thread that someone can go back and take a look, you know, it's overwhelming. With the pandemic, people are just, I think, tired, and we get a lot of information and epic updates, and there's a link somewhere in the bottom of some email. It requires, you know, the design is there, and then our job is to educate constantly that that's an information and giving examples. At least even with our residents, I just described to them during ACP, this is the ethics, this is the things that you guys reviewed during these sessions. And I said, and the ACP navigator, this is how it behaves. And I think it's just one provider at a time at this point, and just illustrating the importance. I think there's a surprise also when you toggle something and say, oh, wow, it's you know, like it just changed, you know, like my note will have an impact on what people are seeing visually. But these are not widely adopted. And the challenge for me is also that these are not very well studied things. So it's one thing to have HIM do it, and we're kind of doing many changes. Like there's a lot of enthusiasm. So I would say there is ways, but it just requires a lot of patients' education and persistence. Yeah, and because the reality is these safety events, right? They're patients that are DNR and they get coded, and they're people that are, you know, so there's a disconnect there. So there's a lot of safety events that can occur. Deb, what are your thoughts on that question?
Yeah, I agree. I think it goes back to a lot of what we were saying, and this big principle of, like, the more you can put things in one place for people to find, the better. And we do a similar thing at Providence. As you were saying, we have, and I think I mentioned this really briefly, we have what's called an integrated goals of care note, which is a smart phrase, which uses sectioning smart links to basically you can put a goals of care note in any other kind of note that you're already writing. So you use it as a dot phrase, as a smart phrase, but the system tags it, basically like puts a hashtag on it and extracts it to that ACP summary page. So anytime anyone uses that dot phrase, it goes into that list of goals of care notes. So whether it's the oncologist, the hospitalist, the PCP, the physical therapist, it goes into that list. You can all review them in one place, but people don't have to write a separate note or use a specific note title. They can do it in their consult note, in their progress note, in their telephone note. So it captures all of that and puts it in one place, which I found to be very useful.
That does sound really helpful. Marty had a question.
Deb, I'm not trying to call you out, but I'm curious because I saw you twice now say goals of care notes, and you specifically use the air quotes. What do you mean when you use the air quotes with goals of care note? Because I think I know what you mean, but maybe not.
Yeah, no worries. Yeah, thank you for asking me to clarify. I use the air quotes because in Epic, when you write a note, there's a note type. So that note type can be a consult note, a progress note. And there are specific note types for goals of care or advanced care planning. So if someone writes a note under the note type of goals of care, We also then have essentially a smart text that goes along with that is based off of the serious illness conversation guide. So people have a structured framework for that. However, if they're using our goals of care integrated to our dot phrase, they'll be writing their regular progress note. It'll be a note type of progress note, but it'll still be tagged as a goals of care note by our system and pull the text from that specific piece of the note into our ACP summary, which then gets linked to, and then you can go to the full note. But in that dot phrase, you have the option of writing what we call a brief goals of care note, which is very brief. It's like, who was there? What did you talk about? But then it also has the ability through that smart phrase, you have options to write either based kind of off of a brief serious illness conversation guide framework or a straight like advanced care planning framework that's more like based around the foundation system pieces. And those are both used widely by our primary care physicians. That's what they were built for, and that's what they wanted. Again, not to have to go to a totally separate note to do, I did advanced care planning today, but it's still tagged in our system and can be found easily as a goals of care note. Does that make sense?
I'm glad I asked, because I thought of something different. I mean,
okay.
Because when I, like, for example, seeing a patient today and I search goals of care notes, 22 notes pop up and I read them all. And what I notice is that almost always they're outcome-based goals of care notes, not value-based goals of care notes. And so when I hear goals of care, that's kind of what first comes to my mind, because there's a lot of value-based goals of care notes in people's charts that'll say if they want CPR or not, but I don't really get that glimpse of who are they? What are their values? Can you help me make any other decisions besides not wanting CPR or not?
Yes, exactly. Yeah.
I was gonna say, Marty, to an extent though, and we are at time, so maybe I'll add this and then thank our speakers. And sorry, Kim, that we didn't get to your question, but I would just say that I think there's a huge distinction. It probably makes it very hard to have these discussions about the EHR between the process of having these discussions and what is expected to be discussed and what's actually important versus the actual technical components of the chart. So Marty, whether you agree or not that was a goals of care discussion, having a way to get it stored, I guess, is kind of more the EHR part of it. So thank you both so much. This was a really great talk and I really enjoyed it. And I hope everyone else did, and we appreciate it. Good luck with your presentation at AHPM. And thank you both so much.
Thank you for having us.
Thank you.